Welcome everyone to the March 11th, 2021 COVID-19 clinical rounds. These rounds today are focused on pneumothorax, pneumomediastinum, and COVID-19 patients. My name is Richard Hunt. I'm an emergency physician who serves as Senior Medical Advisor at the National Healthcare Preparedness Programs in the Office of the Assistant Secretary for Preparedness and Response at the United States Department of Health and Human Services. The purpose of these rounds are peer-to-peer, real-time sharing of COVID-19 challenges and successes. If I'm a clinician caring for COVID patients, the clinicians I want to learn from are those with the most experience. This is a voluntary public-private collaboration. Thanks to the multiple professional organizations who have collaborated, and thanks to the leaders from those organizations who are panelists on these rounds, much appreciated. These rounds are not intended to be redundant or replace any organization's initiatives. They are intended to be sharing of clinical experience rather than recommendations or guidance. These ECHO clinical rounds you are now participating in are focused on clinicians sharing their successes and challenges with other clinicians. Thanks to the National Emerging Special Pathogen Training and Education Center, NETEC, for their support with these rounds. NETEC's webinars complement these Project ECHO COVID-19 clinical rounds. Thanks to Project ECHO, Dr. Bruce Strominger and his stellar team for the peer-to-peer learning platform we use for these rounds. COVID-19 clinical rounds currently are all US noon Eastern time. Mondays are EMS rounds. This coming Mondays will be looking at the year ahead with EMS and COVID. Tuesdays are critical care rounds. Dr. Jeff Dichter is going to be coordinating that particular session next week. And then Thursday, we will be doing emergency department rounds as per usual and get reconnected with school nursing as schools are starting to reemerge in terms of like opening their doors to kids. So also I want to point out that on Wednesdays, HHS has an emerging outpatient therapeutics series that's currently focused on monoclonal antibodies. At this juncture, I'll now turn it over to Dr. Bruce Strominger with Project ECHO.
Thank you, Rick, and welcome to everyone participating, including our guest presenters and panelists, and in particular to all the participants taking time out of your busy days. Just going to run through a few housekeeping and logistic items. We really look forward to your questions about today's important topic on pneumomediastinum and pneumothorax, and please put those in the Q&A function, and we'll be reviewing that and hope to get to as many questions you put there as we're able to. If you've got any questions about technical or logistic issues, please put those in the chat and we'll try to help you out. We are recording today's session as we always do, and your attendance is consent to be recorded. Thank you for that. The presentations today will be shared along with the recording on the Clinical Rounds website, and I think Samantha will be putting a link to that in the chat momentarily if she hasn't done it already. We are offering CME and continuing professional development credits through the University of New Mexico, where Project ECHO is based, and we'll be putting a link in the chat about 15 minutes before the end of the session to a 2 to 3 minute survey. We really look forward to your feedback. It helps guide planning for future sessions and quality improvement of what we're doing. And there should also be a link in the email announcement that went out today. And you've got 48 hours to complete that to get the instant CME. Just as a reminder, these learning sessions are focused on improving patient care and health systems and supporting clinicians. So please let's keep them apolitical and non-commercial. Thanks for that. And just a word about data use. The data you share with us, we keep confidential. And what we do share with Rick and Asper is all de-identified. As Rick mentioned, NETEC, the National Emerging Special Pathogen Training and Education Center, has been a partner in this initiative since the beginning, nearly a year ago. And They have a great webinar series, as Rick mentioned. We'll share a link to that in the chat. And there's an archive of all the sessions they've done over the last year. Also, the Association of American Medical Colleges is a partner, and they have been maintaining a great clinical guidance repository, and we recommend you check that out, and we'll share a link to that in the chat as well. Rick, back to you for the crowdsourcing question.
Thanks, Bruce. We all learn from each other with the crowdsourcing responses, and really would encourage you to respond to this one. On this 1-year anniversary of the WHO declared pandemic, what comes to mind first? We've been through quite a journey over the past year since that WHO declaration, and it's worth reflecting on that and see what comes to clinicians' minds on that. I'd like each of the panelists to please go ahead and unmute themselves. And I'll ask each of you to please introduce yourselves quickly, and I'll start with Sandy Schneider. Sandy.
Hi, I'm Sandy Schneider. I'm the Associate Executive Director for Clinical Affairs for the American College of Emergency Physicians, and I'm also an emergency doc.
Thanks, Sandy. Carol Cunningham.
Good morning. I'm Carol Cunningham. I'm the State Medical Director for the Ohio Department of Public Safety Division EMS.
Thanks, Carol. Harry?
I'm Harry Seibold. I'm an EM and EMS physician from Helena, Montana. I'm a consultant with the U.S. Forest Service and currently on a long-term COVID assignment in Texas.
And Dan Gerard.
I'm Dan Gerard. I'm a registered nurse and a paramedic. I'm the EMS coordinator for the City of Alameda Fire Department. I'm trying to catch my breath right now. And I'm also the president-elect of the International Association of EMS Chiefs. Good morning.
Thanks. And Ronnie?
I'm Ronnie Stewart. I'm a trauma surgeon. I'm medical director of trauma programs for the ACS, and I'm out of San Antonio, Texas. Thank you. Thank you, Rick.
Carol?
Oh, I already introduced myself.
You know what? I'd like to focus on your background. And what the heck is that back there? I mean, like the thing with like to the other side of the door. What is that?
Oh, I call it contemporary art. That's
Okay. All right, cool. All right, just checking. All right. So Dr. Jolly, I see you down there lurking without your video on. What's going on?
Yeah, that's me. Till Jolly, emergency physician in the Northern Virginia area, and been working to support HHS on telemedicine and COVID, and working directly with Rick on this year-long enterprise.
And for those of you that don't know, part of why we're even here today is because of a lunch meeting that I believe, impromptu luncheon that Dr. Struminger and Dr. Jolly had at CDC many months ago. So anyway, yeah, thanks for my tangents this morning. We'll now turn it over to our first speaker, Dr. Emmanuel Econom. He's a third-year cardiology fellow at Inova Heart and Vascular Institute at Inova Fairfax Hospital, and an incoming electrophysiology fellow at Mount Sinai Hospital. Emmanuel, as I mentioned to you in our green room, we just began having like the words pneumothorax, pneumomediastinum on rounds back in January, with a conversation from an intensivist from Cedars-Sinai and Harry Seibold, who said, yeah, I seen some too. And then your paper came out like a week and a half ago or so. And it's like, as I said, I fell off my chair. So it's particularly like full circle. It's actually quite something when we talk about something, then actually the paper comes out. So Emmanuel, welcome, and I'll turn it over to you.
Sounds good. Well, Rick, thanks a lot for having me. I would say it's serendipity. It would be the best way to look at it, particularly with the connections you have to Inova as well. I'm glad we got you vaccinated. But to introduce myself to everyone, first of all, thanks for having me, and to the attendees, thanks for joining us. As he stated already, I'm Dr. Emmanuel Econom, cardiology fellow here at Inova Fairfax Hospital. And I'll be giving a brief report on spontaneous pneumothorax and COVID-19. and also sharing some of our experiences here with our INNOVA study. Rick, should I go ahead and share my screen now? Good. All right, so we'll go ahead and get started.
Looks great. Thanks.
Things here. Great. So I think as most people on here know, so coronavirus disease 19, COVID-19, as it's referred to, has been associated with significant morbidity and mortality. Some of that has evolved as the therapeutics around this disease and as we understand it has evolved as well. But our understanding of the clinical spectrum of disease continues to evolve. Because of the nascent nature of the disease process and the pandemic, this has really been, limited to, word of mouth, social media in some cases, and on the empirical side, case reports, case series, as physicians make observations as they treat some of these patients. And we try to report that so that other physicians and clinicians and healthcare practitioners can leverage from that experience. One of the complications that has come about from this is spontaneous pneumothorax. It's emerged as a concerning complication in these patients, particularly those hospitalized with COVID-19. And there are some signals to suggest that this might be related to worsened outcomes. So to touch on just a little bit of background on the epidemiology of spontaneous pneumothorax, when you look at primary spontaneous pneumothorax, so this is just in general population in patients, at least at that time, not with a known underlying pulmonary disease, it's relatively rare. It's a high incidence in males at around 0.02%, and much less in females. And the classic risk factors are usually male sex, smoking, more of a thin, morphinoid sort of appearance. And it's thought that the pathophysiology of this is related to underlying subpleural blebs or bulla that actually result in this spontaneous pneumothorax. But that's sort of the hypothesis. It's actually not fully understood. As it pertains to secondary pneumothorax, which is usually in patients with underlying lung disease, whether that be COPD or some other inflammatory process, the incidence of that starts to increase. I know Dr. Williams will touch on that a little bit more. But of note, usually in patients, ventilated patients, where you have higher sort of barometric pressures and you have some barotrauma and volume trauma, then you have a higher incidence of spontaneous pneumothorax in that cohort. The highest of which is usually in patients with acute respiratory distress syndrome, also referred to as ARDS. So that brings us to COVID-19. This is the pandemic we've been struggling with now for over a year. And as I stated, really it was somewhere around February, March of last year, a little bit earlier on internationally, where you started to sort of get whispers of this pneumothorax entity, and people were seeing a case here and there. And as time progressed, the knowledge of that started to rise a little bit. But really on the anecdotal side, again, there was little empirical evidence. So the estimated incidence, it's anywhere from 1 to 2%. And it runs the gamuts in the different papers that have been published so far. This has largely been limited to retrospective case reports and case series. So that brings this to myself. How did I get involved with this, particularly as a cardiologist within my training? So at the peak of things, as part of the first wave here in Northern Virginia, a hospital was really sort of pushed to its capacity. We're opening multiple COVID units. And I was actually tasked with opening a COVID unit and running that with our critical care partners, myself. So this was around that sort of April, May period of time, again, as part of that first wave. And so we would round and see some of these patients, and I started to notice, and we would have some patients who clinically, their progress was sort of static, not getting better. Couldn't really put our hands or fingers on what was going on. We would get the follow-up x-ray. We know some of the inflammatory changes that you see, the classic pulmonary infiltrates that are associated with COVID. But we weren't specifically looking for pneumothoraces. But yet, I took care of 2 or 3 patients within a span of several weeks to a month who would get x-rays and they would have impressive pneumothoraces, some of which are visualized here, as you can see, where you have your lack of lung architecture. And so we, trying to understand, why is this happening? And I hadn't seen anything like this before. And that's really what spurred the project that we took on here within the Inova Health System. Around the same period of time, as I stated, you started getting whispers on, social media, Twitter, WhatsApp, people talking to themselves. I'm reaching out to people at other institutions. Are you seeing this? And I actually pulled this off of Twitter, and someone had, had stated on there, spontaneous pneumothorax in COVID patients not on positive pressure. Are people seeing a lot of this? This is actually word for word from a Twitter post. And those were the same questions I had. And so we took on the study. We conducted a retrospective study of patients admitted with COVID-19 at 5 different hospitals within the Inova Health System here in Northern Virginia, but it really spans outside of Northern Virginia as well. This was within a 3-month period between February and May of 2020. As part of this study, we identified 1,619 patients admitted during this period of time. And we're able to hone into 22 patients who were actually diagnosed with spontaneous pneumothorax without an associated sort of traumatic encounter or anything like that, in order to really determine it's spontaneous. And so this is from the paper we published in Heart and Lung earlier this year. And this goes into some of the baseline characteristics of these patients. Now, because of the sample size being, just 22, you're going to be limited to some of the significant inferences you can make. But from a descriptive standpoint, this was certainly quite helpful. And so, we took the 22 patients and we subdivided them into patients who were alive and who were deceased at the time of the study, and just to try to get a better understanding of what we were seeing. Key things, a few things that sort of caught our attention would be that, some of the deceased patients tended to be still a little bit older, but likely not statistically significant there. Certainly more overweight with a BMI of 28 as opposed to a BMI of 23. This was largely a Hispanic population that we were looking at. 95% of our cohort were Hispanic. That might relate to some of the referral patterns that we have here at our specific hospitals of interest. But nevertheless, it's something that caught our attention. And as it pertains to the underlying comorbidities, fairly comparable across the groups. We also looked at the home medications that they were on. The incidence of underlying pulmonary disease is relatively infrequent in this cohort and equally distributed. And the admission symptoms were classic symptoms for COVID-19, so nothing exciting there. And so we delved a little bit further and looked at inflammatory markers associated with COVID-19, and these were things that we were already looking at in patients admitted with COVID, i.e. D-dimer levels, ferritin levels, CRP, fibrinogen, and LDH levels, which were markedly high in this patients. And as you can see, you start to see that there's a clear pattern there where you have much higher inflammatory markers in the patients that actually had a worse prognosis, in this case, mortality, both for ferritin levels, for CRP, and fibrinogen levels as well. We then also looked at the median inflammatory markers at the time of diagnosis, and you have the associated interquartile range in parentheses there. And again, you see the trend towards higher inflammatory markers, particularly patients who suffered a worse prognosis, as opposed to the patients who remained alive. I think what was particularly interesting to me, and one of the reasons why we carried out the study, was the fact that, as you can see here, 50% of the patients were not on a ventilator. You have patients on nasal cannula. We had 18% of the cohort just on nasal cannula. And then you have some patients with some positive pressure in terms of bilevels with high BiPAP or just high flow nasal cannula. So you have 50% of the cohort here having spontaneous pneumothorax, not on a ventilator, which to us was relatively new. The other thing to highlight here is that this oftentimes was diagnosed well into the hospitalization itself. And again, in some cases, they were looking for it. In most cases, they were not. So to summarize our study, the incidence of pneumothorax in our cohort was 1.4%, which falls in line with some of the published literature. The mortality rate in our cohort was quite high at 36%. And when we compared it to the crude mortality of all patients admitted with COVID-19 during that same span of time, during those 3 months, that was 15.8%. So you can see it's significantly higher in this cohort. Again, limited sample size. Deceased patients were more likely to be older, more likely to be overweight, with increased inflammatory markers, and a higher prevalence for hypertension, diabetes, and heart failure. So our hypothesis was that the marked inflammatory response, fibrosis, and in some cases, the need for positive pressure ventilation was contributory to the development of pneumothorax in our cohort, specifically here. And so you take a step back, and as I alluded to before, there had been other studies that had been undertaken since we started our study, and we'll publish it right around the same time or a little bit later in 2020. Bring your attention here to Miro et al.'s study, which was actually out of Spain. I found this to be an impressive study. It looked at 61 Spanish emergency departments, had a total of 71,000 patients with COVID-19. And the 61 emergency departments actually represents 20% of all the emergency departments in Spain. So this is a great sample size. And so what they did was a case control study where they looked at patients with COVID who had spontaneous pneumothorax. They looked at patients without COVID who did not have spontaneous pneumothorax. And then they looked at patients with spontaneous pneumothorax who did not have COVID, just to see if they could find any signals of interest. And what they saw was that COVID-19 patients with pneumothoraces had increased leukocyte count, lymphopenia, and increased hospital death compared to the other two groups, which is consistent with what we reported. Their incidence was around 0.5%, at least as it's reported in the paper. Wong et al. Also had a case series that they published, and this was out of New York, which is one of the epicenters of COVID at its peak. And they looked, they identified actually 75 patients with COVID-19, and this was largely an ARDS cohort who also developed spontaneous pneumothorax. Now, this is a high-risk cohort to begin with. 92% of their patients were ventilated despite lung protective strategies. They still had pneumothoraces. Most of these patients were classified as severe ARDS, and their inpatient mortality was 76%. So quite high, but the mortality associated with ARDS is quite high to begin with. So just something to highlight. And so in summary, I think, the way that we've looked at this, particularly when we're looking at spontaneous pneumothorax within COVID-19, is that one, we know that it's associated with mechanical ventilation. We've seen that before. If you have underlying pulmonary disease, and in this case, it'd be secondary, COVID-19 being one of them, you can see that as well. Most importantly, I think what's unique to COVID-19 specifically is going to be the level of inflammation and fibrosis that's associated with this process. And we think this is one of the main sort of drivers of pneumothorax in this cohort. And that is all I have. I will open it up to you guys shortly.
Emmanuel, yeah, thank you very much. While you're taking those slides down, there was one question just for clarification. There was a question about whether or not these were all hospitalized patients, and my inference is certainly they were, but I just want to make sure others hear from you that yes, indeed they were.
Great question. Yeah. These were all hospitalized patients. So these were patients hospitalized within our health system with COVID-19 pneumonia.
Great. And let's see, for the panelists, any questions? Dan? Yeah.
Just a couple of questions. One is how much of this is related to ventilatory pressure, density of infiltrates in the lungs due to COVID-related ARDS, and is there a time correlation? I think all of these things, probably come into play. And and in the COVID patients that we saw with that had ARDS, it just seemed that the infiltrates in their lungs were much thicker than I had ever seen in my career. Thank you very much. Great presentation, Doctor.
Thank you. So I think that's a great question. And I think that, our study juxtaposed specifically to the Wong et al. Study coming out of New York probably answers that a little bit. So I think the interesting thing with our cohort is that 50% of our patients were not ventilated. And so you're talking about 11 patients who developed pneumothorax, really oftentimes just on nasal cannula, which has no positive pressure associated with it, and high flow. There is some pressure associated with high flow and bilevel, but certainly not to the extent of a ventilated patient. And you still had pneumothoraces in that setting. And so that really speaks to the fact that there's something a little bit more unique going on there. And we think that's just because of the severe inflammation, fibrosis, and that's highlighted by some of the inflammatory markers. Now, if you look at the cohort of patients coming out of New York with their series, and they largely had an ARDS cohort of patients, and you had 92% of patients there having pneumothoraces. I think that speaks to your point. I think ventilators and the pressures associated with that definitely can induce pneumothoraces. But that is also in an era where we understand this already pre-COVID, and there are lung protective strategies being applied. So that is happening in spite of that. Dr. Williams will touch on that a little bit more, but I think that's what's interesting here with the COVID pneumothorax cohort. Another quick point to add there is that as opposed to some patients who have pneumothoraces and there'll be an acute change, in this case, sometimes you really don't know, you sort of stumble on them. So you have to be attuned to that fact and you have to go look for it. I think there are a few more questions. I see.
Yeah, thank you. Yeah, let me do Carol and then Harry, and then we got to get to Dr. Williams for his presentation for sure. So let's see, Carol. Yeah.
In terms of treatment, for those patients who were, say, managed on nasal cannula, did you have to place chest tubes in all of them? You know, some smaller pneumothoraces in a normal situation, you watch and follow them, but I was just wondering how many of those, due to COVID and maybe not even related to COVID, required a Heimlich valve or a chest tube versus observation?
Great question. So so I think about 72% of our cohort, or in the 70% range, required a chest tube. But in some cases where it was very small, maybe not bilateral, and the patients were not clinically declining, we just sort of observed and had more conservative management, and those patients got better. You're absolutely right. In some cases for pneumothoraces, you just watch and wait, and things sort of improve. But in our cohort of patients, about 70% of them were managed with chest tubes.
Thank you.
Thanks. Okay, I got Harry and then Sandy. Then we got to get to Dr. Williams.
Thanks for the great presentation, because this really follows on with some of the observations that several of us in completely different areas had made. And I agree with you, at least anecdotally from my experience, about inflammatory markers. I'm wondering if anybody, you or any other scientists that you know are trying to tie immune modulation and perhaps decreased rate of some of these complications in a study, or if you'll look at that in a second version of the study.
Yeah, so that's a great question. I think that's broadly, I mean, if you step outside of pneumothoraces in general and just looking at COVID-19 management, I think that is something that is being addressed. I think immune modulators, I had part of that as part of my table, were actually being utilized early on when some of the clinical trials were still ongoing. You know, it was very interesting when I was taking care of these patients. We were using therapies that were still in trials. And then while still taking care of the patients, the trials results came out, and then they went on formulary, and you sort of followed on with some of their therapies as well. So I think it is something that's being looked at. We're not looking at that specifically. I think some members of our critical care team are looking at that from a study standpoint, but certainly.
Thanks. Sandy.
Yeah, just a real quick question. Have you looked, excuse me, have you looked back to, at their entry, because this is an emergency department rounds, have you looked back at their CTs, their initial CTs, their ultrasounds, even their chest x-rays, to see if there was an early sign of something small that just got bigger? And then the other thing, other question I have, many of these look like they're sort of segmented pneumothoraces, as opposed to, I mean, I know you showed the one where like the whole lung was gone. And do you think that has to do with the inflammation?
So great question. So I think to answer your second question first, I think yes. I mean, at least we hypothesized that, you know, part of that certainly has to do with the inflammation, and essentially is a marker of the severity of disease. Is sort of the way we look at it, particularly when you tie that to mortality. To answer your first question, yes, we did go back and try to take a look, sat down with the radiology department to see. So the diagnosis of pneumothoraces, I think the median time of diagnosis was about 9 days into the hospitalization. At this point, you had patients in the hospital for weeks. Oftentimes, no, this was not present on admission. The other interesting thing, and this is also in the paper, only 2 patients actually had a CT scan during the entire hospitalization. And it speaks to sort of the evolution of care. Initially, CTs were being used as a diagnostic sort of modality for COVID-19. Obviously, that has logistical implications when you think about the management of COVID patients and things like that. And so I think, particularly within our health system, we sort of went away from that after the first couple of months. And so unless there was a compelling indication to get a CT, we weren't just getting a CT to sort of clinch a diagnosis. I think laboratory markers, PCR was doing that for us. We felt confident in that. But there were one or two patients who had CTs, one who required a test tube that was a little bit complicated as well. You have sort of belay that can develop in this. So the CTs can actually be helpful there in the correct placement of a test tube. Because you want to make sure that you get into the space that you need to get into. But again, I'll defer to Dr. Williams on that.
Manuel, that's a great segue. I will say editorially, as sort of like the moderator's prerogative, in my entire career, I have never heard of a presentation on pneumothorax or pneumomediastinum from a cardiology fellow. It is stunning, and congratulations.
Thank you.
With that, I'm going to introduce Dr. David Williams. David, really appreciate your joining us. David is the Director for Critical Care and Director of the ECMO program at Sharp Memorial Hospital in San Diego. So David, welcome, and really looking forward to hearing from you.
Thank you, Rick, and it's a pleasure to be here speaking with all of you. I will share my screen. Can you see that? Okay, so coincidentally, it was 1 year ago this week that we started to experience a big surge in ICU admissions of COVID-19 patients here in San Diego County. And within the first couple of weeks, I was starting to observe a fair number of patients who had some manifestation of barotrauma, and these were invasively mechanically ventilated patients, okay, in our intensive care units at the three hospitals here in San Diego County that my partners and I work at. That was somewhat shocking to me because in the era post-ARDS network, where we've used low tidal volumes and limited our distending pressures, we really don't see much mechanical ventilation induced barotrauma like we did years before in the late 80s and the early 90s when I was in training, and we kind of let it rip in terms of tidal volumes and airway pressures. So I thought that something unusual was up and wanted to look a little bit further into that. What I'm showing you on the screen here is a handful of the early patients that we saw with COVID-19 who had barotrauma. And you see that it kind of runs the gamut of all the types of barotrauma that you will see in mechanically ventilated patients. First panel up top, there's some pneumomediastinum. Next to that is a patient who has small bilateral apical pneumothoraces. Down below the one on the left is a patient who has extensive subcutaneous emphysema and pneumomediastinum and pneumoperitoneum. The panel next to that is from that same patient. So we were starting to see a fair number of patients who had barotrauma while on mechanical ventilation, which was unusual in my recent experience in the way that we managed patients with ARDS. So we thought that we would look a little bit further into that. Now, prior to COVID-19, barotrauma was clearly recognized not infrequently in patients on mechanical ventilators, and especially in acute respiratory distress syndrome, which is, as Dr. Econom pointed out, is the highest risk group of mechanically ventilated individuals to develop extrapulmonary air. However, the incidence of barotrauma in mechanically ventilated ARDS patients had been decreasing over the latter period of the 20th century, possibly related to the refinement of our ventilatory techniques, but definitely clearly lower than what we used to see. And just to sort of put a figure on it, several meta-analyses and outcomes from prospective clinical trials shown down at the bottom of the screen had indicated an incidence in the 2000s to 2010s of around 5 to 10% in patients mechanically ventilated with ARDS. Now, one of the things that I did literally in the first week after I saw 2 or 3 or 4 patients with barotrauma was I thought, is there something about coronavirus itself that makes them more predisposed to barotrauma? And if so, did anybody look at this back in 2003 when we had the first SARS epidemic known now as SARS-CoV-1. And so the first thing that I found in the literature search was the article from Garmersol, where they presented a 26% incidence of barotrauma in mechanically ventilated patients. And I recognize that as extraordinarily high and nothing that we would have seen in non-COVID patients. And the other four you see there, there was a range from 12 to 34% incidence of barotrauma. In Cowell's case, they only considered pneumothorax as barotrauma, so it was probably actually higher. So that suggested that maybe there is something unique to the coronavirus infection itself that might be playing a role here. We don't know that for sure, but certainly is hypothesis generating. So then in looking then at some publications that have come out over the last year now during the pandemic, I looked recently to see, which studies had a denominator of patients who were mechanically ventilated. And these are all mechanically ventilated. We'll talk a little bit more about, the spontaneous non-ventilated patients. But here again, you see a range in COVID-19 from 13.6% to as high as 40% of patients on mechanical ventilators who experienced barotrauma. Early on last spring, when we did start seeing this, I asked a research associate of mine, Julie Catherine Graham, to help me look at some of our first few patients with barotrauma. And so we did a quick study looking at the first 13 patients that we had. There's not a denominator here that's valuable because this was a convenient sample, but we did compare them in a case control fashion with patients with COVID-19 in our same intensive care units who did not have barotrauma. And you see there that the kind of barotrauma we saw, 9 of the 13 patients had pneumothorax, 8 had pneumomediastinum, 7 had subcutaneous emphysema, and 1 each had pneumoperitoneum and pneumopericardium. And the majority of them had multiple types of barotrauma. So usually you'd see subcutaneous emphysema and pneumomediastinum or pneumothorax or what have you. In those cases, the mean time to barotrauma after intubation was 4.8 days. These cases were very early in the pandemic. There were a few patients with well-preserved lung compliance, a kind of subgroup that Dr. Gattinoni has written about and suggested that maybe higher tidal volumes would be reasonable. So our mean tidal volume in the group was 6.9, but not far off our usual target of 6 mils per kilogram predicted body weight. An interesting thing we found, and these were small numbers, so this is probably a statistical anomaly, but we did find a significant statistical correlation of elevated ferritin levels and of the use of convalescent plasma with the onset of barotrauma. So again, very small numbers, and despite the statistical phenomenon, really just hypothesis generating. We have innumerable more patients, and we just ran out of time to study them when our second and third surge came, but we hope to look at that over time. At this point, my partners and I in the group I'm in have taken care of over 700 invasively mechanically ventilated patients with COVID-19. That means over 700 ARDS patients because they all have it. There have been many dozen cases of barotrauma. Now, back to the notion of spontaneous non-mechanically ventilated patients having a pneumothorax that Dr. Econom has nicely discussed. As he pointed out, there are cases of what we call primary spontaneous pneumothorax, usually healthy young adults who have blebs in the apices. Secondary spontaneous pneumothorax, asthmatics or COPD, where there's an underlying lung disease that results in this. Inhalational drug use, and here in San Diego, we have a lot of aficionados of methamphetamine. And so we do see this from time to time where there's insufflation and pneumothorax or pneumomediastinum. Obviously blunt or penetrating chest trauma, including that caused by us iatrogenically. and catamenial pneumothorax in patients who have deposits of endometriosis on the pleural surfaces. However, in addition now, just like Dr. Khanum, we too have seen this with some frequency in non-intubated patients with COVID-19, including some patients who were on BiPAP or non-invasive ventilation, but many who never received positive pressure ventilation in any form, either just nasal cannula or the limited positive pressure that you get with high flow nasal cannula. So very interesting phenomenon that seems to be somewhat unique to COVID-19. Now, there was a reference to the management of barotrauma in mechanically ventilated COVID-19 patients, and there's obviously no confirmed right or wrong way to do this, and a lot of what we do is based on our prior experience with management of extrapulmonary air in the pre-COVID era. But I think, obviously, I think we'd all agree that if a patient on a mechanical ventilator has a large or attention pneumothorax, immediate chest tube placement is indicated, and there's not a lot of debate about that. There are, however, some references in the literature, and the references are listed below, about some sort of fine points that I thought were fairly interesting and appealing to me. One was the notion that perhaps in these patients, the use of a percutaneous tube thoracostomy using the Seldinger technique, and there are some products out there that do that, versus the usual open thoracostomy where there's an incision and blunt dissection, may be preferred, because with the latter, you may get more of a rush of air into the atmosphere and more potential for aerosol generation. But with either of these approaches, and by the way, I almost 100% of the time use a percutaneous Seldinger technique in my practice, with or without COVID. But despite how you do that, there is a risk of aerosol generation. There's a risk of lung penetration and injury, and of hemorrhage, especially in anticoagulated patients, as many of these are. So we have to think about where and when we really do need to place a chest tube or not. There may be a role, and I would suggest that there is, for expectant management with close observation. Now, I'm talking about predominantly pneumothorax, because I think few people in the current era would suggest putting a chest tube in just because of subcutaneous emphysema, or just because of a small non-tamponading pneumomediastinum. We always worry in patients on mechanical ventilation, because they, by definition, have positive pressure, about a small pneumothorax turning into a large one. And I am old enough to reflect back to an era when there were people, textbooks, articles that suggested in ARDS, if patients had even the slightest hint of barotrauma, or maybe not, that we put preemptive chest tubes in. Now, we definitely don't do that these days, and I think even less so in the current era. But my experience in COVID-19 is that we've had a number of patients, including one that I showed in the second slide, who had the small apical pneumothoraces, where we did not put chest tubes, and we were able to successfully get them through it without ever developing tension. There may be a role for ventilator adjustments, and again, some of these are anecdotal experience. So I will typically even shoot for lower tidal volumes if possible. We practice permissive hypercapnia in almost all of these patients with ARDS with COVID-19. So we're going to allow even greater degrees of hypercapnia in this setting, trying to lower the PEEP to the lowest level that we can. And when I have barotrauma, I'm changing my risk-benefit assessment to allow higher FiO2s at the expense of lower PEEPs in these patients, in the hope that we can mitigate the barotrauma. Sedation and paralysis may or may not play a role, but certainly if I have someone with barotrauma who's on the ventilator, I don't want them to have any degree of ventilator dyssynchrony, which likely contributes to the barotrauma or worsens it. So we're probably a little bit more liberal with use of paralysis once barotrauma emerges. And then finally, the last point, the role of ECMO, I want to not be misunderstood. I'm not in any way advocating ECMO as a treatment for barotrauma, although it would probably be helpful, but rather in a program where we do provide ECMO to patients with ARDS and with COVID ARDS. We have used the presence of barotrauma as one of the elements in our calculus to help us determine whether or not we are going to put a patient on extracorporeal life support. So if a patient who's otherwise a fair candidate for VV ECMO for COVID-19 ARDS, has the gas exchange anomalies that put them in that category, and they have barotrauma, we're more likely to proceed in that patient than we are to try to bide time and try some other salvage maneuvers. So in summary, it appears to me that pulmonary barotrauma appears to be more common in COVID-19 patients on mechanical ventilators than in prior studies of ARDS in the current era. All the forms of barotrauma have been seen, including pneumoperitoneum, which always raises the specter of bowel perforation. This may relate, I think, to the inflammatory and necrotic effects of COVID-19 infection, and is suggested by the notion that we saw this incidence higher in SARS-CoV-1 as well. It does appear, as Dr. Khanam alluded to, worsen the prognosis in some studies of barotrauma. If you have that as opposed to no barotrauma, your outcomes are probably worse. Makes some sense. It clearly can occur in patients on non-invasive ventilation or even without ever being treated with positive pressure support. And again, some can be managed conservatively, but chest tubes are clearly required for moderate or large pneumothoraces. So with that, thank you for your attention, and be happy to entertain any other questions or conversations.
Thanks, David. I was really surprised and fascinated by your going back to the previous SARS, which was also devastating in its own way, but fascinating to see that background. There's a specific question that came up a little bit earlier, but I mean, you're either of you well positioned to answer it for sure. But do you think that the increased interstitial fibrosis leads to less elasticity, causing this the tissue to rupture instead of stretch?
I think that first of all, that typically with acute respiratory distress syndrome, the pulmonary fibrosis phase of that is later on in the course. What we call the fibroproliferative phase of acute respiratory distress syndrome is typically ensues around 2 weeks or later. Nevertheless, early in the disease process, many of these patients, the majority, do have reduced lung compliance. And again, now that a year has passed, most studies have suggested that these patients are similar to non-COVID ARDS patients in that many of them will have reduced lung compliance. And so, yeah, the stiffness of the lungs may predispose the lung lobule to rupture and leak of air into the interstitial space. But my personal hypothesis, and many others who sort of commented on this in the literature, is that in this case, we have a hyper-inflammatory disease process. We have levels of D-dimers and ferritin and interleukin-6 that, albeit elevated in ARDS patients in general, seem to be at a higher level even than before. And so maybe there is an intense inflammatory process at the alveolar and interstitial level that's causing weakness and necrosis of tissue, leading to more of this. But again,
thanks, David. Yeah, go ahead, Emmanuel. And then I think, Ronnie, it looks like you got your off mute, so I'll turn it over to you after I get Emmanuel's input here.
Sure. Yeah, so I think I'll second a lot of what Dr. Williams has said already. I think the leading hypothesis is one of severe inflammation. And I would also say anecdotally, particularly during the first wave, I mean, this was the first time I would see D-dimers greater than 20 routinely. Like that, I had never personally seen it with many other disease processes. And so it was such that you could look at the inflammatory profile before actually getting your results back and say, okay, yeah, this is a COVID patient. So the signature of the disease, I think the one thing that ties it together is severe inflammation. And so I think, as he's alluded to, I completely agree with that. I mean, usually that fibrotic stage usually does come later in the course. And I think that also is reflected in our study. Early on, you had patients easily in the hospital for weeks on end, particularly patients with severe COVID. And our median time of diagnosis was about 9 days going to 10 days. So you're already approaching a week and a half to 2 weeks, right? So you had the ER cohort from Spain that had about a 0.5% incidence. And that was looking at patients who had pneumothorax at presentation out of 71,000 patients. So the incidence there wasn't as high, but certainly as you follow the course of disease, and especially if that inflammation is not arrested, I think that it certainly would contribute to the incidence of pneumothoraces, but it's purely within the realms of hypothesis at this stage.
Yeah, thanks. Ronnie, and then Ronnie, after your comment or question, I'm going to go to the polls because it will be fascinating to see our participants' experience with this phenomenon. Ronnie, please.
First of all, great presentations for both presenters. Terrific work. We also covered a COVID ICU through both of our, well, I guess technically 3 surges, but really 2 big surges. And, you know, in the second surge, our patients, whether it's because for whatever reason, they seemed to be less ill, they were sick, but we had fewer patients who required mechanical ventilation. And I thought so what we saw basically fits with what both panelists have said, that it seems to correlate more with the severity of the disease than any particular factor. It makes sense from my standpoint, from our standpoint. So I'd just say great presentations. Thank you.
Thanks, Ronnie. If we go to the polls, and there are like about 7 or 8 points, but they're really straightforward. And these are a little bit risky because it might be like 3 of the participants have actually seen this. So we'll see what happens. I was aware of pneumothorax and/or mediastinum in COVID-19 patients independently of anything you heard on announcements for rounds, discussions, or presentations. Give this another 10 more seconds. All right, let's stop there. For something like about 50% of you voted, 40% indicated yes, 60% indicated no. All right, thank you. Next. I have seen pneumothorax and/or pneumomediastinum in COVID patients. While people are responding to this, while we don't, we're going to run out of time because we want to make sure our panelists and speakers have at least a couple minutes to kind of like unwind with any final comments. But we've asked at least on 4 occasions whether or not clinicians were seeing on the rounds, participants on the rounds were seeing new clinical patterns in COVID patients since January 1st this year. And after 4, it might have been 4 or 5 polling on separate rounds, it hovers between 27 and like 40%. So, one of the questions then becomes, is something real there or not? And this, in reference to pneumothorax, pneumomediastinum, barotrauma, certainly it seems like there's something there that we actually was probably going on long before we ever talked it on rounds. And David, you brought that up, and it's like back to SARS-1. All right, let's stop there. 58% voted. Wow, 28% indicated yes. All right, thank you. Next. Okay, this is to the location. And I actually thought about this one a lot. Is it like, are we seeing it in the ICUs? Sandy, to your point, are the EDs picking this up? Is somebody actually like seeing it in the field in EMS? I mean, where is it? And part of that has to do with, its clinical course and how soon, et cetera, et cetera. So we'll get to that question too. I get to see these results as they kind of come in, and it's fascinating to watch this one. Wow.
Yeah, the real life feedback of it is actually, it's an interesting feature. I don't think I've ever seen this in a presentation before. It's really neat.
Thanks, Project Echo, on that one for sure. And Emmanuel, just to be clear, this is not hard science we're doing here. just point. I'm not sure we got a paper out of this. Anyway, all right, let's stop there. This is fascinating. To me, it's fascinating. I just had no idea what this was. I actually, my gut was I thought people would have said late clinical course, but that was going to be where it was. All right, David, does that surprise you that or is it just me?
It doesn't surprise me. Well, what I'm seeing on the poll there, none of that
Yeah.
really surprises me. I think that like Manuel, we have seen patients who had barotrauma when they came in. Now, that
Got it. Okay.
after admission, but presumably even at the point of contact in the ER, they may have had pneumomediastinum maybe. I don't remember anybody coming through any of our ERs who came in with a big pneumothorax needing a chest tube right away.
All right.
But in our mechanically ventilated patients, definitely, it's kind of biphasic, I would believe. There have been patients who had no barotrauma on the chest x-ray prior to intubation. They might have been in the hospital a few days. The immediate post-intubation chest x-ray showed barotrauma. Now, sometimes that might be from overvigorous manual ventilation. But then again, in our small series, the median time to onset was, less than 5 days on the ventilator. But we've certainly seen patients who went into the fibroproliferative phase, never had barotrauma, and then as they really got stiff, really bad, and then, late 2-3 weeks in, developed barotrauma.
Thanks. Yeah, let's get the next question. It's pretty straightforward, the question. I'm not going to read it. Thanks for people jumping on these. Another 5 more seconds and we'll stop this one. All right, Echo, let's stop there. We had 49%, 50% voted. Great. And echoing, no pun intended. Well, maybe it was intended. No pun intended here, but it looks like nasal oxygen, non-rebreather. Fascinating, no CPAP, BiPAP. All right, next. Pneumothorax and/or pneumomediastinum has been the proximate cause of death in some COVID-19 patients. And Harry Seibel is one of my best hall monitors when it comes to the polling. I got to tell you, I struggled with this one. It's like, how would the medical examiners phrase this? I was like, got all twisted up and oh no. Harry, sincerely, you have upped my polling question game considerably since we started many months ago. others in the chat have their own critiques, but Harry, I pay attention to you most. No, that's not true. Pay attention to the chat too. All right, next. Let's see the results. I honestly, personally didn't expect anybody to say yes. I just didn't.
Rick,
I mean-
if I might interject, this
Yeah.
question reminds me of, we have had one case in the whole series of patients that we've treated in the last year who we did put a mediastinal chest tube in for tension pneumomediastinum without pneumothorax.
Wow.
So that is a rare thing, but
Wow.
it does happen. And in my prior critical care experience, I think maybe once or twice in my career have I encountered that. But it is a rare but very interesting phenomenon.
Yeah, for sure. All right. Thanks, everyone. And I think there's only a couple more. They should be pretty quick. Compared to non-COVID patients, identification and clinical management of barotrauma in COVID patients has been easier, more difficult, not sure, not applicable. And this to me is I was trying to get to like the so what? If it's a pneumothorax, it's a pneumothorax, but is there a nuance about COVID and barotrauma that makes it either easier, same, or more difficult? And I think there may be one more question, and then I'll go around the horn really quickly to our panelists for any last comment. And then Emmanuel and David, you get the last word. All right, let's stop there. Nobody said it was easier. All right, next. My approach to ventilation management in COVID patients has changed due to concerns about potential barotrauma.
My own answer to that question is definitely yes. I would say that I and my associates are using maybe lower levels of PEEP than we previously would and accepting a little bit higher FiO2.
Yeah, thank you. David, thanks for putting a fine point on that. That's actually really helpful. All right, let's see these. And then Samantha, if you can, right after this on my cue, if you can put up the slide, because I think it's actually important to put a context around this. We'll finish up by in the next 5 minutes or so. So panelists, if you got something really pertinent, please, I want you to shout out. And then for David and for Emmanuel to have the last word. Okay, let's see these results. And it's fascinating. 19% said yes. And yeah, there's 14 people saying yes or no. I got that, but still, it's a fascinating phenomena. All right, thank you, Echo. Can you put up Samantha? Can you put up the slide? Part of why we're doing this rounds at all had to do with the discussion that started to pop up anecdotally on rounds and in the green room for rounds about seeing new stuff, and particular participants in the chat. And you'll see poll question number 1. We repeated this question over 4 different rounds. Since January 1st, I have seen new patterns of disease in some COVID-19 patients. We've never drilled down to why are there new patterns, or, is it the new strain, or is it because we have more experience or whatever? But clearly there was enough of participant feedback that said there was something there. With a range of 30 to 41% indicating they were seeing something new since January this year. Then for EMS, which was, I found particularly, actually even more fascinating, EMS was seeing some new variations as well, with 26% indicating. So that's how we basically ended up with these rounds. And we're not gonna stop with just the pneumothorax. We gotta I think we owe it to our patients to really try to sort out what those new patterns might be. And maybe they're old, but we're just now recognizing them, as Emmanuel and David have highlighted. So with that, let's turn it back over to our panelists. Any panelists with any final comment? Ronnie, anything from you?
I have a question for our two presenters. I don't know whether maybe you may not use APRV as a salvage or primary ventilation mode, but as part of your response to barotrauma, did you use less APRV, or did it change your practice?
I don't use APRV that much. One or two of my partners like to use it at times, but I did in a couple of patients who were on ECMO who had some barotrauma. I did use APRV as the mode of ventilation. During that, I sort of got away from that.
Thank you.
I'll defer to
A
Dr.
little
Moore.
experience.
I'm usually not intubating patients or, manage an event, so don't really have an opinion on that.
Thanks. Harry? Oh, I'm sorry, Ronnie, you have anything else?
Go
Okay,
ahead.
thank you. Harry, anything?
I just wanted to ask either of the presenters, we're talked a lot about PEEP and those things. Were you looking specifically at plateau pressures in the evolution of this? I noticed there in my patients, there comes a time where suddenly small changes in PEEP make very large changes in peak and plateau pressures, and suddenly I had to pay a lot more attention to those settings and try to manage that. Sometimes we're in what I call the coffin corner, where there was nothing else you could do, but it seemed like there was an evolution that I think had to do with compliance and stiffness.
Yeah, it's a good question. And I would say that in the series that Julie and I looked at, I didn't present all the data. It's pending. It was submitted to the ATS as an abstract presentation, but we did look at ventilatory parameters. And in general, although the P plateaus and PIPs were all within our desired range, less than 30, there tended to be a significant difference in those numbers if you had barotrauma as opposed to not. So those are things that you have to take with a grain of salt, though, because there are correlations that may have to do with sicker patients have stiffer lungs and get barotrauma, and patients who are less sick have less stiff lungs and don't get barotrauma. So just hard to say whether that's ventilatory management or versus just an observation of how sick the patient is. But that also, in one or two other of the articles that I looked at in COVID-19 reporting barotrauma, also found that correlation as well. So it may be real.
Thanks. Carol?
Just a quick comment. I think, we know that COVID damages and scars lungs. It'll be interesting to see as we go into this post period, how many of these long-term patients, pneumothorax or these complications, spontaneous pneumos, be another complication, which will be important certainly for those of us who practice in emergency medicine.
Yeah, thanks, Carol. Sandy? Okay, great. All right, Emmanuel, last word from you, and then David, last word from you.
Sure. Again, thanks for the opportunity to present, and thanks to all the attendees for joining. I think what I would say, and if there's a take home from this for me, would be really clinicians being attuned to the possibility of this being the case. Because I think anecdotally from my experience, empirically from what we saw in the data, and even looking at some of the other cases that have been presented, if you've taken care of COVID patients, I think it's similar to the idea of when you look at the patients, particularly within a sort of sub-cohort of them, they don't look as bad as the x-rays look. I mean, when you look at, the diffuse pulmonary infiltrates, classically, you're expecting a patient to clinically be much sicker than what they are. or you put the pulse ox on and they're oxygenating at 70 or 75%, and you're conversating, and there's a discordance there. And I think what I noticed from our experience is that there was also a discordance with the patients who developed spontaneous pneumothorax, and maybe the acuity of change that you're classically expecting to see. What we did notice, particularly for the hospitalized patients, is if you're treating a patient and they're just not getting better, or if things seem to be a little bit static, you have to be aware that this is a possibility and go look for it. It's not oftentimes going to sort of present itself in that way, and for that reason, I actually think this is actually underdiagnosed, and I think that the incidence and prevalence is likely much higher.
Yeah, Emmanuel, I was really struck by your comment that, some of these patients just weren't getting better, and then you identified this. And so like that, be aware, I think is like, to me, a huge take home as you indicated. David, last word.
Yeah, I'd like to thank Emmanuel for doing the study and publishing it as he did, because I think it's really one of the, maybe the only publication that points out the presence of spontaneous non-mechanically ventilated patients having barotrauma with this. And like him, we saw that as well. I would agree that I think maybe the value of this conversation and our efforts in this is that for clinicians to be aware that barotrauma occurs in COVID-19 and perhaps at a higher incidence than what we would expect in patients with this degree of illness. And it affects their treatment, it affects our management, and it might in fact affect their morbidity and mortality. So obviously a lot more research needs to be done. I think I also would agree that probably the incidence of this, even if we're getting daily chest x-rays, is underestimated, because as we all know, we can better detect small degrees of barotrauma, especially pneumothorax. I mean, Ronnie will definitely attune to that. I'm in a trauma center myself, and many times patients with blunt chest trauma come in and have no evident pneumothorax on chest x-ray, but the CT, which is always done as part of the workup, often will show that. So we're probably dealing with a lot more than what we appreciate.
Yeah, a really quick lightning round question, David. Bedside ultrasound for diagnosis of barotrauma? Yes, no?
Yes and no. If the patient has, well, the enemy of ultrasound is air. So if the patient has extensive subcutaneous emphysema, and many of these patients do, it's just gonna, you're not gonna get good visualization of the lung sliding sign. But in general, yes, ultrasound is probably better than chest x-ray at detecting pneumothorax. But the caveat is if they have a lot of chest wall air or even edema, that might make it less accurate.
Thanks, David. This rounds in particular answered a question I've had ever since Harry and Warren Friedman talked about like this pneumothorax pneumomediastinum. Well, like, so what? Does it matter? And clearly this matters. And I really appreciate the extensive experience that Emmanuel and David brought to this, and your paper. Congratulations again. To our participants, thanks so much for hanging in there well after our hour, and to our ECHO team, stellar. Harry, Carol, Ronnie, Sandy, who was on before, Till, appreciate your being panelists. ECHO, thank you as always. Emmanuel and David, thanks so much. See you on the next one.
Thank you all. Appreciate you.